Welcome to the Deep Dive. Today, we're zeroing in on prostate cancer, specifically what you need to know for the MSRA.
Exactly.
We're aiming for a really high-yield, efficient session here. We all know medical information can be overwhelming, right? So think of this as your shortcut to the core stuff on prostate cancer.
Absolutely. Our mission is to break it down, key components, memory tips, the works, making it easier to recall under pressure.
Perfect. So let's dive straight in. Prostate cancer. In simple terms, what is it?
Okay, so at its heart, it's a malignant tumor. It's found in the prostate gland,
Right.
which, as you know, sits just below the bladder in men. And it happens because cells there start growing abnormally, sort of uncontrollably.
Got it. So the key words are malignant.
Malignant, yes.
Yeah.
Prostate gland, below the bladder.
Yeah.
And abnormal cell growth. Those are the 4 pillars.
Malignant means it can spread. That makes sense. So what actually causes this? What's the etiology?
Well, like with many cancers, the exact trigger is still a bit unclear. But it's generally thought to be a combination of things. Genetics definitely play a part.
Right, genes.
And environmental factors, too. We know specific gene mutations, like in BRCA1 and BRCA2, significantly increase the risk.
Ah, the BRCA genes?
Yeah, those are important. And then you have hormonal factors, androgens, specifically in just getting older. Age itself is a factor.
So it's a mix of your inherited makeup and, well, life happening. Who is most likely to get it then? What are the big risk factors?
Okay, several things increase the odds. Age is definitely a major one. The risk really climbs as men get older. Think over 50, definitely higher risk.
Right.
Family history is another key factor. If your father or brother had it, your risk goes up.
Makes sense. The genetic link again.
Exactly. Ethnicity is also significant. Men of African Caribbean or African descent have a higher risk compared to, say, white or Asian men.
Okay.
Then there are those BRCA gene mutations we mentioned.
Yeah.
And increasingly, obesity and being overweight are recognized as risk factors, too.
So summing up the main ones: age, family history.
African ethnicity, BRCA mutations, and obesity. You could maybe remember AFB-U if that helps.
AFB-U, okay, could work. So we know who's more at risk, but what's actually happening inside the gland itself, the pathophysiology?
Right. So it nearly always starts in the glandular cells, the ones that produce the seminal fluid.
Okay.
What happens is genetic mutations basically switch off the normal controls for cell growth. So these cells just multiply unchecked.
Uncontrolled, right?
Yeah. And then they can invade nearby tissues. Critically, they can also metastasize.
Spread elsewhere.
Exactly. Break away and travel to distant sites. Bone and lymph nodes are the most common places they spread to.
Right, bone and lymph nodes.
And another key point, the vast majority, over 95%, are adenocarcinomas.
Adenocarcinomas.
And they usually start in the peripheral zone of the prostate. That's important because that's the area a doctor can often feel during a rectal exam.
Ah, so potentially detectable earlier.
Potentially, yes. And one more thing, these cancers can grow at vastly different rates. Some are very slow growing, almost indolent, while others are really aggressive.
That's a crucial difference for management, I imagine.
Absolutely.
So if someone presents with urinary symptoms, it's not automatically cancer, is it? What else could be going on? The differentials?
That's a really important point. Yes, several other common conditions can cause very similar symptoms.
Like what?
Well, top of the list is probably benign prostatic hyperplasia, BPH, just an enlarged prostate, very common in older men.
Right, BPH.
Then there's prostatitis, inflammation of the prostate. That can cause pain and urinary issues, too.
Okay.
And you've got to think about urinary tract infections, UTIs, also bladder or kidney stones. Even bladder tumors can sometimes present similarly.
So quite a few possibilities. How do you tell them apart?
Investigations are key. The PSA blood test is often the first step. Yeah, prostate-specific antigen.
Yeah.
But a raised PSA needs follow-up. It's not diagnostic on its own. The definitive diagnosis comes from a prostate biopsy, usually guided by transrectal ultrasound.
The biopsy is the gold standard then?
It is.
Okay, so we can't just rely on symptoms. Let's zoom out a bit. How common is this? What's the epidemiology like, especially in the UK?
It's very common. In the UK, it's actually the most common cancer in men.
Wow, most common.
Yeah, the lifetime risk is roughly 1 in 8 men.
1 in 8?
And it's predominantly diagnosed in men over 50. We see around 52,300 new cases diagnosed each year in the UK.
That's a huge number.
It is. The peak age for diagnosis is typically between 75 and 79 years old.
Okay.
And we see that ethnic variation again. Most common in black men, then white men, and less common in Asian men.
That's consistent with the risk factors.
It is. Globally, it makes up about 15% of all male cancers, but it's more concentrated in developed countries that 70% of cases are found there.
So a major health issue, particularly for older men here. How does it actually show up? What clinical features should we look out for?
Well, the tricky thing is early prostate cancer often causes no symptoms at all.
Right, asymptomatic early on.
Exactly. Which is why awareness and things like PSA testing are debated but important. When symptoms do appear, they often relate to urination.
Okay, like what?
Things like needing to wee more often, especially at night, a sudden urgent need to go, difficulty starting the flow, or a weak stream stopping and starting.
The classic LUTS symptoms.
Precisely. Lower urinary tract symptoms, weak stream, hesitancy, urgency, frequency. You might also see blood in the urine or semen, though that's less common.
Blood hematuria or hematostromia.
Yes. Erectile dysfunction can also be a sign, or sometimes pelvic pain or discomfort.
And how is it often first suspected?
Often, it's picked up because of an abnormal finding during a digital rectal examination, the DRE.
Feeling the prostate.
Yeah. Or because of an elevated PSA blood test level. On DRE, a cancerous prostate might feel irregular, hard, or nodular, rather than smooth and firm.
Irregular and hard red flags.
Definitely. Knife guidelines suggest considering prostate cancer if a man has those urinary symptoms, erectile dysfunction, or visible blood in the urine, particularly if they have risk factors.
And important to remember, it can mimic BPH early on.
Very important. Symptoms alone aren't enough.
Okay, so let's say there's suspicion abnormal DRE, raised PSA symptoms. What investigations follow?
Right. So the PSA blood test is usually done first or alongside the DRE. But again, elevation just signals need to look for
Not diagnostic.
not diagnostic. Things other than cancer can raise PSA like BPH or prostatitis or even recent ejaculation. NICE now recommends a multi-parametric MRI scan of the prostate as the initial investigation for suspected localized cancer.
MRI first now.
Yes, that's the current NICE guidance. It helps assess the likelihood of significant cancer and can guide the biopsy if one is needed.
Okay, so MRI, then potentially biopsy.
Exactly. The transrectal ultrasound-guided prostate biopsy remains the gold standard for confirming the diagnosis. It takes small tissue samples.
Got it. Any other tests?
You might do urine analysis to rule out infection, check renal function, and if there's concern about spread, particularly with higher PSA levels or more aggressive-looking cancer on biopsy, an isotope bone scan might be done to check for bone metastases.
And then staging.
Yes, crucial. We use the TNM system, T for the tumor size and extent, N for lymph node involvement, M for metastasis.
TNM standard.
Standard. And then there's the grading of the cancer cells themselves, looking at how abnormal they are under the microscope. That's the Gleason score.
Right, the Gleason score. How does that work?
Basically, a pathologist assigns a grade from 1 to 5 to the 2 most common patterns of cancer cells seen in the biopsy samples. Grade 1 looks quite like normal cells. Grade 5 looks very abnormal.
2 grades.
Yes, the 2 most common patterns. These 2 grades are added together to get the Gleason score, ranging from 6, usually 3 plus 3, up to 10, 5 plus 5.
So higher score means more aggressive.
Generally, yes. A score of 6 is usually considered lower risk, 7 is intermediate, and 8 to 10 are high risk. There's also a newer system, the ISUP grade groups, from 1 to 5, which correlates with Gleason scores and is perhaps a bit easier for patients to understand.
ISUP 1 to 5. Okay.
And for localized disease, we combine the Gleason score, or ISUP grade, the PSA level, and the T stage to put patients into risk stratification groups. Low, intermediate, high risk, basically. This really helps guide treatment choices.
That makes sense, combining all the info. And NICE has specific referral thresholds based on PSA and age?
Yes, they do. Different PSA levels trigger a referral depending on the man's age group. It's worth being familiar with those thresholds.
Okay, that's a thorough diagnostic pathway. So once you have the diagnosis, the stage, the grade, how do you decide on management?
Management is highly individualized. It really depends on the stage, the aggressiveness, the Gleason score. We talked about the patient's overall health, their age, and importantly, their own preferences and values.
Lots to consider. What are the main strategies?
For low-risk localized cancer, especially if it's slow-growing, active surveillance is often a very good option.
Just watching it closely.
Essentially, yes.
Yeah.
Regular PSA tests, DREs, possibly repeat MRIs and biopsies. The idea is to avoid or delay treatment and its side effects unless the cancer shows signs of progressing.
Okay. And if treatment is needed for localized disease?
Then the main curative options are radical prostatectomy surgery to remove the whole prostate gland,
Surgery.
or radiotherapy. That can be external beam radiotherapy or internal radiotherapy called brachytherapy, where radioactive seeds are implanted directly into the prostate. Sometimes a combination is used.
Surgery or radiotherapy.
Those are the mainstays for cure in localized disease. For cancer that's locally advanced or has spread, metastatic, the approach shifts. Androgen deprivation therapy, or ADT, becomes central.
Hormone therapy.
Exactly. Prostate cancer growth is often driven by testosterone, so ADT aims to drastically lower testosterone levels. This can be done surgically by removing the testicles.
Orchiectomy.
Or, more commonly now, using medication. LHRH agonists or antagonists are the main drugs.
Okay, ADT for advanced disease. What else?
If the cancer becomes resistant to standard ADT, which often happens eventually, then other treatments come into play. Chemotherapy, typically with drugs like docetaxel first, then maybe cabazitaxel.
Chemo.
Newer, more potent anti-androgen drugs like enzalutamide and abiraterone are also used in that hormone relapse setting.
Newer hormone agents.
Yes. And for some men with specific genetic mutations like BRCA positive metastatic disease that's hormone relapsed, targeted therapies such as olaparib, a PRP inhibitor, can be effective.
Targeted therapy. PRAP inhibitors.
Right. And throughout all this, palliative care is vital. Managing pain, especially bone pain from metastases, using things like radiotherapy or bone-targeted agents like bisphosphonates or denosumab, and managing other symptoms to maintain quality of life.
Palliative care is key at all stages, really.
Absolutely.
Yeah.
And we have to talk about side effects. Treatments like surgery and radiotherapy can cause urinary incontinence and erectile dysfunction. ADT causes things like hot flushes, fatigue, loss of libido, potential bone thinning, mood changes.
Significant side effects?
They can be. Sometimes intermittent ADT is used cycles of treatment on and off to try and reduce the burden of side effects. We also need to manage the initial tumor flare that can happen with LHRH agonists by using anti-androgens for the first few weeks.
Right, the flare.
And providing support for psychosexual issues and offering treatments for erectile dysfunction is really important. Bisphosphonates might be needed to prevent osteoporosis from long-term ADT.
So a complex landscape of treatments and side effect management. What about the overall outlook, the prognosis?
It varies hugely. Depends heavily on the stage at diagnosis, the Gleason grade, the PSA level, the patient's health, and how the cancer responds to treatment.
Understandably variable.
But generally speaking, if it's caught early, when it's still confined to the prostate, localized, the prognosis is often very good. Many men are cured with surgery or radiotherapy.
That's encouraging.
Survival rates have definitely improved over the last few decades, partly due to earlier detection, likely linked to PSA testing, and better treatments. However, it is still the second most common cause of cancer death in UK men.
My second most common killer.
Yes. And mortality is higher in older men, those over 75. For metastatic disease, while treatments can control it, often for years, it's generally not considered curable. But even there, outcomes are improving.
So early detection really makes a difference.
It really does.
Even with treatment, what complications can arise either from the cancer itself or the therapies?
Good question. Complications can certainly occur. The biggest one from the cancer itself is metastasis spread to bones, lymph nodes, sometimes lungs or liver. This can cause pain, fractures, and other problems.
Metastasis.
Then, treatment side effects can become long-term complications. Urinary incontinence and erectile dysfunction after surgery or radiotherapy are probably the most discussed.
Yeah, quality of life issues.
Big time. The side effects of hormone therapy fatigue, hot flushes, loss of libido, potential for osteoporosis, gynecomastia can persist as long as the treatment continues.
Right.
The tumor itself, if it grows large, can cause urinary tract obstruction, potentially leading to kidney problems if not managed.
Obstruction.
And if cancer spreads to the spine, there's a risk of spinal cord compression,
Yeah.
which is a neurological emergency.
Serious stuff.
Definitely. So regular monitoring and proactive management of both the cancer and the side effects are essential to minimize these complications and support the patient's overall well-being.
Okay, so pulling all this together for someone revising for the MSRA, prostate cancer is clearly a major topic. Understanding its definition, the causes and risks, how it develops and spreads, how we spot it, investigate it, stage it, the different treatment options based on risk and stage, the general prognosis and potential complications. It's all crucial.
Absolutely. It's a high-yield area. Knowing the basics of presentation, the initial investigations like PSA and MRI, the concept of Gleason grading and risk stratification, and the main treatment modalities like active surveillance, surgery, radiotherapy, and ADT, that forms a really strong foundation.
And remembering those key differentials like BPH and prostatitis is vital too.
Couldn't agree more. Early awareness, prompt investigation when needed, and properly tailored management are what make the difference.
And it's worth remembering this field is always evolving, isn't it? New research, better therapies emerging all the time.
Constantly. So staying updated is key for any clinician.
Absolutely. Well, hopefully this deep dive has given you a solid framework for your revision. For more excellent MSRA resources, definitely check out passmsra.com and also freemsra.com.
Resources.
Thanks for joining us for this deep dive.